Hi everyone, my name is Associate Professor Tania Pizzari. I'm here with Dr. Sarah Warby.
Hello.
Hello. So my role here at Trobe University is to oversee the Masters of Sports Physiotherapy and the Masters of Musculoskeletal Physiotherapy programs. Also do a little bit of teaching into those programs and obviously still work clinically, treating mostly shoulder injuries.
Thanks, Tania. And as Tania said, I'm Dr. Sarah Warby. I did my undergrad PhD at La Trobe under Tania, and I'm a clinician at the Melbourne Shoulder Group that Tania is also affiliated with Lynn Watson and Simon Bolster and the crew. I run research as well for Greg Hoy, orthopaedic surgeon, and also the clinics research, and I'm an adjunct here at La Trobe.
Absolutely.
Yeah.
And we have done a Learn.Physio series previously on instability. So we do love talking shoulders, and that's what we're going to be doing today. So a little bit of a fireside chat. We thought we would go with some of the questions that we get asked when we do teach physiotherapists in the realms, and also when I do teach the postgraduate physios here at La Trobe, I get asked these common questions, and Sarah and I speak about this kind of stuff all the time. Also, what is kind of out there a little bit in social media world. So the first one that I've put up there on the screen there, Sarah, is that we hear a bit, this does go around social media, but the idea that you can strengthen the rotator cuff and the scapula will follow. So basically, kind of don't worry about the scapula so much, just strengthen the cuff and everything will be okay. What are your thoughts about that?
Oh, okay. So, I mean, the shoulder is a really different beast to any other joints. I mean, the thing is when you strengthen the rotator cuff, you're not considering its base. And the scapula, it is the foundation of the house, I sort of tell my patients. It's got to be in the right spot so the glenoid is orientated properly to take the humeral hedge, but also so the rotator cuff can work in that best length tension relationship. So, I mean, I see a lot of instability, so I think about it from an instability point of view, that, you know, where the scapula is and its stability will affect that centering of the humeral head. But even for all our patients, if we're trying to get the best out of our cuff, we've got to make sure the foundations are good first. So I would wholeheartedly disagree with that in the majority of cases. And I say majority because there's always exceptions to the rule.
For sure, yep. Yeah, I mean, sometimes, it's not often, but I agree, sometimes you see those patients where the scapula is actually functioning quite well, the biomechanics are looking pretty good, and you can maybe skip forward a little bit and go straight to the rotator cuff. But the majority of patients certainly that I see, realistically, if you don't start with that foundation, as you say, the rotator cuff are just not going to work efficiently and effectively. And I think you really have the issue then that you're starting to actually overload the cuff. When a lot of people are coming to physio or to different health practitioners because the cuff is actually overloaded in the first place, and potentially that's the generator of their pain and the reason that they're coming to see you. So yeah, I think I agree that I disagree with this statement. There's a little bit of research as well, so certainly it's not necessarily great research that's out there, but I think for the rotator cuff, there was a recent systematic review published just this year where they had 11 studies looking at the addition of scapular-based exercises, but they also had some weird stuff in there with scapular manual therapy and things like that. And when they looked at all of the data together and synthesised that, they certainly showed that the addition of some scapular-based rehabilitation was had greater results over and above just, you know, the usual rotator cuff exercise, particularly for rotator cuff or impingement. They called it subacromial impingement syndrome, and certainly even post-operative rotator cuff pathologies too. So there's evidence out there. As I said, the evidence wasn't the greatest evidence. Amazing. It was RCT based, but they're really quite small RCTs. And so there's some stuff out there, and certainly purely from an evidence-based point of view. There is one study that I really like that's out there. It was an RCT done back in 2012 actually, but by Teresa Holmgreen and crew. The thing that I like about this study, they actually looked at scapular sort of focused exercise plus some rotator cuff, and they compared it with just neck and general shoulder strength exercises. They looked at, there was 55 people in each group, it was an RCT. They included people from a waiting list of people waiting for shoulder surgery. So it's kind of, you know, the kind of that quite degenerative, probably degenerative cuff kind of population. They've been deemed appropriate to have surgery, and they're just waiting for that to happen. So they basically did a 12-week program, either this scapular-based program or just general strengthening. And at 3 months, interestingly, you know, the people that did that scapular-based program were actually much better in their outcome measures. And probably most importantly, 80% of them didn't actually want to have the surgery anymore, or didn't need to have the surgery anymore, which I think is really amazing in that sort of population as well. But the thing that I like about this paper, and I'll always talk to my students and other physios about this, is when you look at the exercises that they've prescribed, they're kind of exercises that I think are quite relevant to the population and appropriate for the population. And I know we'll talk about exercise selection later on. But I think sometimes when you look at evidence, like RCT-based evidence, and you know, you can get a little bit weighed down with the results and say, oh, this is better than this, or this is, you know, you could do this and it's the same as this. But when you actually delve in and look at the exercises that are prescribed, I often think, I would never give that to a patient. Yeah. Like, that's much too much load, or they haven't looked at the scapula enough, or like, I think that's something with the evidence that is probably missed a little bit.
Yeah, no, definitely. I think, and that's a really good encouragement to people, look at the trials and what they give patients. Yeah. And I think we were even saying this in our last chat, a lot of the exercises we think, oh, I couldn't imagine where that would be appropriate for some sort of, for patients that they're doing.
Yeah, absolutely. But getting back to the scapula and the importance, I think, you know, we've obviously done a lot in the space of instability, and particularly multi-directional instability, or MDI. So what are your thoughts in terms of the scapula there?
So, like I was talking about with instability before, there's a lot of instability that we see as physios, mainly that kind of micro-traumatic or non-traumatic instability. Obviously we see the traumas as well, but especially in this population, the scapula is a real contributing factor to the instability. I'll take MDI, or multi-directional instability, as an example. There's multiple studies that show they have significant downward rotation of their scapula, and you know what we sometimes, you know, what you might colloquially refer to as winging, but that internal rotation of the scapula. Yep. And it's that malpositioning that really drives the sulcus sign, so that inferior instability, which is a quintessential sign of multi-directional instability. But also lots of other instabilities we'll see that are just have a hypermobile base. They tend to be downwardly rotated as well, and that's a big driver. And you can see it when they move in the clinic. They'll have a lack of upward rotation, they'll have internal rotation, or what you might call winging. And you know, what we do in our assessments, and Tania and I talk about this a lot, is that we might see, well, hey, do we think the scapula is driving that instability and their symptoms? And we'll often do those symptom modification procedures, or those corrections, where we'll hold the scapula into a more, you know, a better position for them, and see if that improves their symptoms further. And often it does, and that then you can reasonably infer, well, hey, the scapula is really driving that off-centering of the humeral head. And as part of my PhD, that the wonderful Tania was a supervisor of, we actually did a randomised controlled trial. And it's, to my knowledge, still the only one, the only RCT in MDI. And we had these people with multi-directional instability with scapular dyskinesia, and we looked at 2 different rehab programs. We looked at one program that was typically standard, so the Rockwood instability program, and there was no scapular work whatsoever. So they just did cuff work, bit of push-ups, bit of extension. And then we did what's called the Watson instability program, or it might be called the WIP. And this program has a really big focus on normalising aberrant scapular motor patterning and getting that really nailed before you start to work on the humeral head and then progressing that through their range. And what we found is that there were huge differences between the groups at 12 weeks, 24 weeks down the track in terms of what we call patient-reported outcome measures. But also really interestingly is that there was a really big difference between these groups a year down the track, even though they'd stopped doing the rehab. And, you know, what we sort of hypothesised that if you sort of teach someone to move properly, as in put their, you know, show them how their scapula should be and, you know, reorient their motor control around that good base, you can sort of hold those improvements for a longer period of time. And you know, and we see that work clinically as well, not just with the research. And that's been shown with multiple studies we've done in MDI as well that drive scapular function first. And I think, you know, reasonably it makes sense, even if we're thinking about something like the kinetic chain. If we want to offload a distal segment, you know, for a tennis throw or a baseball pitch, you want to make sure the proximal segment is good.
The core segment is good as well. Yep, absolutely. And what about in posterior instability? You'll see that as well.
For the scapula, yeah, definitely. Yeah. So, you know, there's obviously lots of different grades of posterior instability, but again, the ones that we see a lot are those microtraumatic and atraumatic posterior instability patients. And they can have scapular dyskinesia as a contributing factor to their problem, but it also can be an adaptive issue. So and you probably see this a lot as well, Tania, in posterior instability, patients can often, especially when you move them into flexion, which is a position they don't tend to like, patients will often wing their scapula as a protective mechanism to try and keep the glenoid more under the humeral head for a bit of bony support. Yeah. So it is really
bringing that glenoid around so the humeral head has something to sit on, and so that it doesn't get driven backwards out of the joint.
Yeah, so you can imagine if you're out here, what's a way you can protect yourself? If you wing the scapula around, you've got a little bit more support. Yeah. So, I mean, if that's the driver, when you correct those patients, they can sometimes feel a little bit worse if you put the scapula into like back on the thorax.
Really retracted, yeah.
And in that case, you might start having to work the back of the posterior cuff to give it a bit of coverage to then let the scapula follow. But, you know, that's probably in a, you know, 20% of cases.
But you wouldn't ignore the scapula completely anyway.
No, because
be careful about taking away that strategy that they use.
Yeah, definitely. And I think it's down to like we were saying the other night, the patient you see in front of you and those corrections that you can use. If you hold the scapula in a certain position for this patient, does it make their objective tests better? If the answer is yes, you've got a pretty good pathway of what you're going to fix first.
And it's a pretty good marketing tool as well for the patient. Like if you can position the scapula and then get them to do a movement or an activity, like the asterisk sign that was causing them significant symptoms, and you correct that by moving their scapula appropriately, and it takes away their symptoms, then they're pretty much sold on whatever exercises you're going to give them to replicate that as well.
And before I forget, another good thing about, you know, those corrections is a lot of these patients that we see, you know, that are unstable and, you know, in a bucket age of under the age of 40, they often have this cuff pain because of the underlying mechanical issue. It's not primary cuff pathology. It's created from this misalignment mechanically. So if you go loading the cuff in these painful sort of positions, you're often just irritating their symptoms further.
Yeah, if you're not correcting that scapula. Yeah, because I think the days of us considering that there is primary pathology from, you know, the big bad acromion pushing down or, you know, spurs growing and stuff are kind of gone. We really understand that it often is the driver of the biomechanics of the shoulder and the humeral head and where it's actually sitting in the glenoid. So I think that's important. And there was a Delphi study done a few years ago on that posterior instability. It wasn't just us that says the scapula is important, like all of the experts involved in that study also identified that a focus on the scapula, particularly in posterior instability, is important.
Yeah, and there's been a systematic review on that as well. I think McIntyre, they say that the scapula is really important in posterior instability. And there's a really large Delphi study of international shoulder experts around the world. So yeah, that's a big recommendation.
Yeah, yeah. And so going on from that, I guess, we've talked a lot about scapula. We often see people with dyskinesis of the scapula. Something that I see a lot clinically of people who've been referred. In fact, I saw one just on Wednesday, and they're often given an exercise called the push-up plus, which most of us know. You're pushing into that flexed kind of position, and then you go a little bit further into protraction of the scapula. Really common when people have a deficit that they might think is occurring in serratus anterior. Someone might have that winging, or as you talked about before, that internal rotation. So they're given this exercise as a way to overcome that and strengthen up serratus. I find it problematic. Your thoughts?
I'll let you talk about the research about the subacromial space as well. But first, if we're talking about a patient, one who's either hypermobile or has posterior instability in the early phases of rehab, this is somewhat contraindicated, because patients with posterior instability, posterior dominant multidirectional instability, a lot of them are posterior dominant, have issues in flexion. That is where they've got their problems or their symptoms. And then so putting them in weight-bearing flexion, which is a very challenging position for a joint that's hypermobile, often gives them cuff symptoms.
Yeah.
Yeah, so for early stage rehab, this is quite problematic and hard for them to control, and puts them in a position that's initially their position of provocation. So there's other ways you can get serratus. When you do what we usually do with our patients, because a lot of them lack that upward rotation, they're sitting in downward rotation, we'll often do an upward rotation drill, or what's called a shrug. And you, through all your studies, have shown that actually does, that maneuver to get them into upward rotation does have really good serratus anterior activation.
Yeah. And I think that's the thing, we did a systematic review again a few years ago now, so I can understand why it happens, because the review showed that doing a push-up plus, you do get maximal activation of the serratus. So if you're looking at a patient, you go, well, they've got a weak serratus, hey, I know the best exercise for that, push-up plus. So I kind of understand where it comes from. But then understanding, as you mentioned before, that patient in front of you, and saying, well, is it appropriate for that patient? Because we know that there's biomechanical research to show that when you do a push-up plus, you get an increase in that internal rotation and that downward rotation, which you talked about before in terms of MDI. And it does reduce that subacromial space, it puts people in more that impingement type position, but also it does maximally load the cuff too. So when you look at the EMG research, that exercise puts a lot of load through the cuff. So if you've got someone who does have a serratus deficit, is it appropriate for them? So is it safe? Do they have a grumpy cuff that they're coming to see you for? You're going to maximally load that cuff, trying to actually activate the serratus, but it's probably could be actually making their problem a whole lot worse.
Yeah, and when you talked about, maybe you're in clinic and you think, oh, they have some winging, it's a serratus anterior problem. But like we mentioned before, it could be an adaptive problem. And so it's not actually serratus, it's their coping strategy. And they need some upward rotation and to start giving some support to the back of the shoulder so that they stop then that adaptive strategy. Yeah,
absolutely. And I think with weight bearing, I'm always a little bit careful. I'm just wondering, is it functional for that patient? So I see a lot of patients who've been given, some push-up plus or some weight bearing for the shoulder, even some proprioceptive type work, and they're, a 70-year-old person who doesn't really need to weight bear. That might need to push up from a chair, or but they don't. But that could be painful for them. But they don't actually need to be doing push-ups or significant amounts of weight bearing, and it's probably actually blowing it up their cuff a lot. So really, that function is important for the patient.
Yeah, and exactly that patient in front of you, that patient-specific care, because we can have all these protocols, but you really want to tailor it for the person in front of you. So, your tennis player doesn't necessarily need to, who's got posterior instability, doesn't necessarily need to be training their shoulder in a closed kinetic chain way for their optimum function.
Yeah.
But that's not saying we can't do it eventually.
No.
Like a gymnast that I saw last week that we just getting to the end stages of rehab. We would not do that at the start. That would have given him a huge amount of symptoms. But once the back is strong enough and the scapula's all normalised, then we need to get into weight bearing.
Yeah, of course. Yeah. Yes, if you're treating a rugby player or a football player, they need to be able to push, they need to be able to land, get up off the ground really quickly without any symptoms. So I think that's really critical. So yeah, definitely that patient-specific care is important.
And just in terms of proprioception, I just think, I don't think the jury's out on open chain or closed chain. It really depends again on, they both open and closed chain are good for proprioception, but again, down to the patient and where their pathology is at the time.
Yeah. And I think also the specificity of the activation of the muscle, like, almost in every other area of the body and with the exercises that we choose, we always consider, what's the muscle, what are we trying to get out of the muscle? And sure, like the push-up plus gets a high activation of serratus, but how are you training it? You're training it to be an internal rotator or a protractor. Like, are we actually retraining it to be an upward rotator? And it's the same with trapezius exercises and doing your ITY type stuff. Are we just training it as a retractor and sometimes a downward rotator, depending on the position that you're getting them in? And I think, what do we want from that muscle? If you want it to be upwardly rotating, which is common, then let's train it as an upward rotator. And as you mentioned before, there are other ways to train serratus, like the upward rotation shrug is really great. The research in that systematic review showed that you get a whole lot of serratus with just a flexion exercise. So some sort of, flexion-based exercise, you'll get some serratus. And in those earlier stages might actually be much more appropriate for your patient.
Yep, totally agree.
Yeah. And I guess in terms of, I always talk to the postgrads about, exercise selection. Like, we're not saying never ever do the push-up plus. And I would agree that we should never, there's not a terrible bad exercise that you should never do for shoulders. But I think you've got to pick the right exercise for the right patient at the right time. Yeah. And I see a lot clinically where people have seen other practitioners and they come, and the exercise is not a terrible exercise. It's often it's the execution of the exercise, or that it's just much too much load for them. It's not appropriate for their capacity at the time. So I see a lot of long lever type exercises, which I think can be quite problematic for particularly cuff-based patients, so cuff tendinopathy and partial tear type patients. And I know there's a bit of literature out there with just going through the range in long lever, but I feel like that's, for a lot of patients, that's not the most appropriate thing to do.
Yeah, and so again, for our unstable sort of younger patients, that long lever is very hard for that glenohumeral joint to control on that that humeral head to control on that small glenoid base. One, if your scapula isn't perfect, but having just that long lever, especially in early stage or even half stages of the rehab program, it's just a lot of torque for it to cope with, and it often gives them symptoms. And as we said, a lot of them will have cuff symptoms anyway. Yeah. And so again, I don't like that necessarily either. And then, with our older type patients, I'm starting to think about how the actual tissue is coping.
Yeah.
So if they've got problems when they're lifting out the kettle, trying to pour their cup of tea, or reaching out and they've got lateral pain, you think supraspinatus is a real problem.
Yeah.
Loading them up when they're already showing signs of reactivity, often, well, I could say 100% of the time, my patients make them worse.
Yeah.
I can't think of a patient where they've had pain in a specific motion and I've loaded them and it's made them better.
Yeah.
And I think that might be completely different for the lower limb, but we've got to think about the shoulder in a completely different way, because so many factors. It's got that unstable base. It blends with things like the synovium, the capsule, other rotator cuff muscles that have all got these opposing forces. It's a really different beast.
Yeah, and probably, that goes quite nicely into our third thing.
Oh, yes.
And we get asked, I get asked, and I'm sure you do
Yeah.
as well. So is it okay to train with some pain in the upper limb like we do with the lower limb tendons? And you kind of touched on that there, but you're saying probably not.
I mean, maybe we'll be proven wrong in years to come, but, through the hundreds and hundreds of shoulders that I've seen, if there's pain, it's often one, as we said, a mechanical issue, especially in that younger, unstable MDI hypermobile population. And I say to my patient, if it's hurting, it means that you've lost the control of the movement. Yep. The shoulder's not sitting stable anymore. You're either fatigued and it's losing control, and or you've started to overload the cuff past its tissue capacity.
Yeah.
And same with my, older type patients, that if they're getting pain, that tendon is getting irritable beyond its loading capacity. And as I said, I have never loaded anyone. They've come back and said, I did your exercise, it hurts a bit, but now it's much better. It's never happened. I can't think of a time it's ever happened.
No, absolutely. And when I get asked that question, I'll always say exactly that same thing. And I think the key thing is the shoulder does give you flags, it gives you clues that it's not coping with it for whatever reason, whether it's synovium, whether it's tendon, we don't really know, but it's kind of identifying, I'm not coping with this exercise. So my preference is not to have pain at the time of the exercise. And I always say to patients, obviously where are you feeling it? You say, for an example, an external rotation, you expect to get a little bit of burning kind of sensation around the back because the muscle's working, and it's really important to try and differentiate, is that just because the muscle's working and it's getting a bit fatigued, or is it your pain? So you really want them not to feel their pain. And certainly within the exercise at the time, you certainly don't want them to feel it afterwards and, that night or the next day, because we know, as tendons react, it often isn't until that night or the next day that they really feel it. But I do feel like the shoulder gives you clues at the time. And so you should avoid that almost at all costs. And that's for your rotator cuff, but also, as you mentioned, for your instability, is that it generally means that you're not in the right position.
And while you're just talking about external rotation, because this is something it might be a nice clinical pearl that we talk about often, is that we find external rotations given way too early because it does require a lot of control. And, in both sets of patients, whether it's your older reactive cuff or your younger patient, you've got to have your scapula right before the humeral head is centered and well enough to do external rotation.
Yeah, and I guess with pain as well, like you mentioned, it can be like a mechanical type issue, but there are kind of corticospinal constraints and considerations as well. Like there is some evidence to show that there's a decrease in corticospinal excitability when you have chronic infraspinatus tendinopathy, and that is related to chronicity rather than intensity of pain. So if you think about that, like if you're always exercising into pain, then you're actually increasing the chronicity of their pain as well. So I think it's important to have a bit of a break and let the systems kind of recover as well. It does impact the firing of motor units, that's been shown as well, and just that altering the motor patterning. So we talk a lot about motor patterning and the importance of that for shoulder, and you mentioned that with your MDIs, you know, that they, even after a year, seem to maintain that motor pattern, and that's because we didn't exercise into pain as well.
Yeah, and that motor patterning component is really important because the shoulder relies a lot in MDI, but a lot of shoulder issues as well, on good motor patterning for restoration of good function. So the shoulder needs good coordination because it's a complex joint. So if we are exercising into pain, and we see this clinically, pain really alters their coordination. And there's a little bit of evidence of that in upper trapezius as well. So if you inject the upper trapezius with saline, something that's nociceptive, just to the upper trapezius, and you do repeated flexion, you actually affect the coordination between upper, middle and lower trapezius for the scapula, which we really need for that beautiful upward rotation. So pain, you know, repetitively, like as you said, that chronicity really affects that motor control. And I think that ties into, you know, it's happening in the corticospinal level, it's happening at the motor unit level, and then at the execution level. Things aren't firing properly if we make it sore in a majority of cases. Yeah.
Awesome. I think that might be all we have time for. In summary, so thinking about the scapula, so don't just think about the cuff, think about where the scapula is positioned. You know, there is dyskinesis of the scapula. Push-up plus may be appropriate for some people, but maybe consider some other ways to actually improve that dyskinesis that you're seeing, particularly if you're worried about serratus anterior. And then finally, I guess, just being careful with pain. At this stage, we would recommend not exercising into pain for all the reasons that we've spoken about. I mean, we could talk for days about shoulders, but we probably should end it there. So thanks so very much for joining me again, Sarah. It's been fun.
Yeah, thanks, Tania. Always great to chat.
Awesome. Thanks, guys.